Right, hello everybody, my name's Annaruby. I'm one of the highly specialised dietitians at Great Ormond Street Hospital. So thanks for joining me for the session today. I'm just going to go through a few of my slides from this morning, and Barbara, do you want to introduce yourself, Barbara?
Yes, I'm Barbara Cochrane. I'm a paediatric dietitian at the Children's Royal Hospital for Children in Glasgow. Thanks for letting me join you by Zoom. I was supposed to be there, but I had an accident a few months ago, so couldn't drive. So it's been really good to be able to join you virtually. So thanks very much for that.
Thanks, Barbara, and thanks to everybody in the charity for allowing us to have a little breakout session for you all. This is the time that we want you to, give us questions. We'll give you as much feedback as we can, as much as we can answer them between the both of us, Barbara. But I'm just gonna go through some of the slides that we didn't go through this morning. So, hyperinsulinism and feeding is the topic. So if we talk about feeding, we really want to know about the importance and how feeding is really important in hyperinsulinism. It's the main pillar of treatment, and it's there's a lot of responsibility on the families for feeding. It's an intensified feeding regimes that can treat HI. The problems we do come across are if we're feeding our patients and a lot of calories and glucose, inevitably they become overweight. We have children who have food refusal, vomiting, and food and eating in general becomes a daily fight. So there is some evidence, but very little evidence. I think, as Karen, my colleague, said this morning about scientific papers on feeding and hyperinsulinism. And feeding is a psychological counterpart to increasing insulin secretion. And it's definitely, the evidence that we get is mainly from the parents and the parents' voices of how they tell us, oh, well, our child's not feeding well. You know, all the problems that arise is from the evidence from parents, really. So I wanted to put this slide up because it gives us an understanding of a patient feedback in the HI Global Registry from 2021. It's very evident here that the use of tubes like NGs, gastrostomies are used with patients who have HI. And you can see the percentages there for yourselves. And the highest percentages are with children who have both tube feeds and oral feeding, as well as we do have some who don't have no tube feeding as well. And tube feeding, the categories are listed there. So the reported feeding issues are very overwhelming, and you can see from this table here. The highest are feeding issues. There's poor appetite, refusal to eat, reflux, problems with textures, gagging, vomiting, unsupported oral skills, slow eating, coughing, and overeating as well. This is a study that was done in 2016 by some of our counterparts as well, showing that feeding problems are persistent in children with severe congenital hyperinsulinism, and so feeding problems occur in a significant proportion of children with HI. This is an audit that we did at GOSH a couple of years ago, and from this audit the results showed that there are feeding issues and concerns with patients. About 87% of those children, 87% had feeding concerns from parental point of view. Not being able to breastfeed was the highest as well, concerns from parents, difficulty in feeding orally, and vomiting on feeding. And this, all in all, is the picture of delaying a discharge for themselves, actually. There's 67% for feeding issues as well. From this audit, the changes of treatment we've noticed our infants are always offered trophic feeds on admission. We're wanting to maintain the orality at the first port of call in the first weeks of life. And feeding on demand from a breast or bottle, sorry, there's a typo there. And blood glucose levels are managed with subcutaneous octreotide, IV glucagon, and small volumes of high concentrations of glucose during the time. So diazoxide is commenced once feeding was established. It shows us from admission, patients with CHI had some kind of feeding difficulty on admission. This is approximately 50% of parents had concerns about feeding on admission. And from discharge, you can see the percentage of 76% with a feeding difficulty on admission were feeding orally or breastfed on discharge. And that, yet again, is 8% of parents had concerns about feeding. So that's reiterated through all of those audits as well. So what are the feeding challenges in this cohort of patients? So the goals, first of all, is to establish a normal feeding regime appropriate for the age of the child, the infant, the volume, the frequency, and for optimal growth. So as every baby or infant with CHI gets older, every effort is made by the dietitian to ensure that their feeding progresses as expected for a child of their age. There are challenges, and there are many challenges, and here are some of the ones that I've listed below. Dietetic input is difficult due to medical management. Babies and infants are often fluid restricted due to diazoxide, but also fluids available are limited due to the high IV glucose volume required to keep their blood glucose level stable. And if nutritional requirements aren't met orally or via nasogastric tube, then the use of parenteral nutrition is used alongside oral feeds as well. And the difficulties are the excessive insulin or medication, which contributes to gut dysmotility, and this causes reflux, as we know, poor tolerance to large feed and feed volumes as well, which then consequently causes vomiting, and they have a suppressed oral intake due to excessive insulin production or adverse side effects of medication, which is the medication diazoxide. An NG tube causes oral sensitivity, and oral feeding experience are affected, and this is when most patients may need a gastrostomy. And it's definitely important that we need psychology involved here, and speech and language input needed as well, because we all work as an MDT for our MDT approach and feeding as well.
When a baby has issues with their blood sugars and they have to start on medication, you know, it's a very worrying time for a lot of parents. How are they going to start feeding? How are they going to manage the feeding? Are they going to manage to keep up the frequency of feeding? So I think, you know, as dietitians, we're very much aware of some of the concerns that parents have. And we're there really to support you as much as we can. When we have babies that get discharged, we have very frequent contact with the parents. So it's on a weekly basis for adjusting feeds. So a lot of issues can be talked through at this point. So you do develop quite a good relationship both with your specialist nurse and your dietitian. And I think really we're very much in awe of parents, how they manage the complexity of the treatment for HI, both feeding and medication, because it is quite time consuming. It's very difficult to cope with everything. So we do appreciate that there's a lot of stress and want to help as much as possible. The feeding issues that Annaruby highlighted, they aren't, not every baby has issues, but a lot of them do, you know, so this is something that we want to help work through them with you. So we're quite interested to find out what your questions are this afternoon, to see what sort of help and support parents in general are looking for. So I don't know if anybody's got any questions at the moment. If you want to sort of kick off.
I've actually got two questions as a grandparent. So the first one really is feeding issues at birth. So my granddaughter had late diagnosis because she had tongue tie, and obviously with one of the issues of feeding, how do you distinguish, and then how do you make sure that that's being dealt with correctly? So that's one question. And the other question was recently, she's only on diazoxide now twice, once in the morning and once in the evening. However, because she had to have antibiotics, then that just threw things out completely. So when you are in a regime, you're quite happy you're going forward, and obviously you have the odd blip, you know, because you have to adjust or whatever. But when you have an added something thrown in unexpectedly, how do you deal with all of the feeding issues that come with HI when you've got to sort of do this other regime alongside it all? Does that make sense? I think it was a really difficult thing to work out, you know, 2 hours before or after feed and 1 hour after food and all of that stuff. It's like, well, which comes first, the diazoxide or the antibiotics, or the antibiotics or the, you know, it was that.
I think, to be quite honest, if it's the antibiotics are for treating an illness, it's a short-term thing. The antibiotics are really important to treat the infection. So that probably, in a way, I don't know if you agree, Annaruby, you need to adjust your feeding regime around the antibiotics. If you have to give them so long before a feed, you would want to time your feeds around that. And maybe have to adjust your timings a little bit, because you want to really you have to treat the infection first.
Right. Okay.
Yeah, that's absolutely correct. You're absolutely correct, Barbara. And we do have an MDT approach, so we will always have discussions with our medical team about, you know, intercurrent illnesses. We need to treat those first, because actually, when children with hyperinsulinism have illnesses as well as HI going on, it can cause high blood glucose levels. So we need to look at all the blood chemistry, and we just have to taper it to the child's needs, really, making sure that they're having, whether it has to be continuous feeds just to keep them stable, or whether we can just maneuver things around the medication that they're having. So it's all done as an MDT approach. And also, the parents also, because it's not only an MDT approach, but we will ask parents, and we are I think as dietitians, we're good listeners, and we like to listen to our parents. At the end of the day, we have to think about regimes that are easy for you when you're going home. We have to think about the timings, what works for you, what doesn't work for you. Are you happy with the feeding regime? So we always have, even though the team have been in, we always have that little bit of one-to-one with you afterwards, or a phone call afterwards, to see you and say, what do you want? What would you like? This is about your child. How can we make it easy for you? How can we make it adaptable for you, for the rest of the family as well? You know, for mum and dad who are working and other children in the household, school runs and everything needs to be incorporated into those. And, you know, the formula that we're using, you know, we always go in and talk about which formulas you want to use, you know, and so we're very open to all the questions that you fire to us.
I was going to ask a question about, you had stats and things for the different types of issues people have, being texture, gang and problem. Do you have any statistics on resolution of feeding issues? A mean time for resolution, be it with an NG tube for a year, would it, and then gastrostomy for a year, would it have an impact on the resolution time, as opposed to a kid who is discharged with hyperinsulinism without an NG tube and a gastrostomy, or is it a mean time? Because obviously everyone will be different.
Yeah, I think that's a really good point, and we don't have any information, or we haven't done any studies, or we haven't done any audits on it. But I think it's an amazing question which we probably need to look into. And I think if we think about it, every child is an individual child, and every child will have different complex needs from a medical point of view. And overall, what we want to do is we take every day by day. We have speech and language therapists involved, and hence why we try to get those professions in really quickly to help with orality, because the quicker we can get speech and language in and try it with orality, the quicker it is for that baby to actually get back to normal feeding. The longer we leave it, the orality is affected. So we want to get in really quickly. And we have got some good, like, you know, we've got some good measures in place, whereas actually sometimes we say psychology and SLTs to go in at first point of call to speak to parents. We had actually did an audit before where parents have said they would like actually to have a leaflet of actually, you know, what hyperinsulinism is as when they come to hospital, who they will be seeing and what are we going to discuss with them, whether it's feeding or if speech and language are going to come and see them. So that's something that's in the kind of, we need to readdress as well. But we have got some good patients where we have seen, and we probably can get this data actually, when the point of call that we've put an NG and we've taken it out for a couple of like 24 hours to 72 hours, and they've got better and their orality does get better. But there are some, you know, figures that also have shown that they need a little bit more help, and that's why we need to move to an NG to gastrostomy and to keep their blood glucose a little bit more safe. And thinking about safety measures when they're going home as well, and from parents' perception, how they feel about coping mechanisms as well. So it's all an integrated approach.
Yeah, I think one of the things is every baby is so different, and it's very difficult to have a sort of general approach because you have to be so individual. What might work for one baby is not going to work for another one due to the complexity of their condition. You know, so, and also the medication, some babies get away with just supplemented feed, some need diazoxide, some need everything. So it's really having to make sure that every baby is treated to the best that we can for their particular needs. So some babies going home with a gastrostomy or a nasogastric tube, or it might be just oral feeding. So, you know, it's really difficult to sort of have a general approach to to the feeding. So it's quite difficult sometimes.
Yeah, and the parents' voices are really important to us. We want to be able to hear you, and we want to be able to learn from things that we can actually do better. How can we make your journey better? What can we put in place to make your child's journey better with feeding as well? So if there's any strategies and like topics that you want us to put forward or work with, we're very happy to work with those as well.
Our son was eating and he had an upset stomach and his food wasn't staying down, and we needed to use the SOS 10 of the hour light. Mm-hmm. And we had all the instructions written out, mm-hmm. and they all made perfect sense to us.
Yeah.
But it was about 3 o'clock in the morning and I couldn't process it.
Okay.
So I was thinking if there was like a video you could refer to that just demonstrated it. So it's, you know, I think proof basically, because that's the way you need to think at certain stages. We did clarify that the phone call and everything was fine. I could explain to us, but you can't make that phone call.
And understandably, being a parent and, you know, not having enough sleep and knowing what you need to do in the emergency is really important, isn't it? But that's a great question, because actually we have got videos, and there is some videos in the making how to make SOS, and there's a video of how to make that up. So we probably need to utilise that and use a QR code to put it on actually, maybe on the websites and things. So we'll look into that.
Yeah, and if we can then share it.
Yeah, absolutely.
That would be fantastic.
Yeah.
That's a great idea, isn't it?
Yeah,
because then you can just do it along with the video, couldn't you?
Yeah, absolutely. And I think it's good for parents who come from different ethnic backgrounds. English isn't their first language, you know, verbal, written problems, and actually just playing a video for them is very self-explanatory. And sometimes when you ring a parent, or you want to talk about, because we do ring parents for their SOS emergency regimes, they're busy, you know, picking up their other children from nurseries and things, and, you know, even making a phone call to speak to them is difficult. So actually when they can relax in their own time, they can say, oh, actually, if I need to use it, I know how to I know I can play the video and I can just remember, so I don't.
It's harder with things that you don't do every day.
Yeah, absolutely. Yeah, absolutely.
I think one thing that we could sort of recommend is keeping a supply in the amounts that you need, because each baby would have, or a child would have, a plan. Keeping ready-made feeds in the freezer, so if you do need to use them in a hurry, rather than have to think, well, how do I make this up again, or what do I add, or how much do I give? If you have ready-made ones in the freezer that you can just lift out and defrost quickly, that might be another way around that.
That's a great idea, Barbara, because I think we do have something of that mechanism in the special feeds unit that we have at Great Ormond Street Hospital, and in other units they probably use the same theory, where they do make these feeds up as an emergency, and it's in the freezer, and actually if there was somebody who's coming in overnight really quickly and they needed to use it, they do have access to that emergency supply. But they do have at ward level the stock of SOS as well. But yeah, I think that's a great idea, Barbara, doing it up in the freezer, so you know it's always there if you ever need it.
See, in regards to the as you're using the SOS tip, how long would you keep your child on the feed? How long would it be until you had to say, right, this isn't working, we need to go into the hospital? Like, is there a minimum time, or?
I think for me, there are 3 things that I'd probably say is checking blood glucose regularly. The SOS is also used for hydration purposes to make sure your child is hydrated if they're unwell. And for whatever reason in the 24-hour period, if that is not helping in terms of if the blood glucose levels are erratic and your baby or child is still vomiting, having diarrhea, the parent's perception is always, and a healthcare perception is always bring them to the hospital, because it's better to be safe and keep them safe.
Yes, I think you probably could go from your ordinary feeding regime, and if you have a pump, then to continuous, and if the baby vomits or the child vomits with that, then you go on to your emergency feeds. If continuously, if you have a pump, or hourly if you don't. If that feed is vomited, then I would go to hospital sooner rather than later.
We would like to hear from you, so if you will have any further questions and you want us to answer questions that you feel like you haven't managed to be able to say today, you can always send them through and we'll happily answer them for you.
Or if you use the feedback form, just plug in the feedback form, you can ask questions on that, and then we can pass them through to.
Yeah, or any topics that you'd like us, to further talk about, or things that may be more interesting that you think that we could talk through, or any kind of ideas that you have that you might want to share with us and say what could be a better way of providing information to you.
Yeah, I think, we do have a dietitians group that we meet on a fairly regular basis, and we're looking for ideas for resources. So it's really useful we know what we think parents want, but you probably think there might be something different that we're not providing. So that would be quite useful to find out. So I'm sure Lorraine or Sarah or Steph can let us know what sort of things people are looking for, because it's quite handy to get some ideas when we're meeting. We're sitting there thinking, oh, what do we think people want? But that might not be what you want. You might want something different. So feel free.
Yeah, absolutely. We're always looking for ideas to make things a bit more exciting, a bit more understanding for you all, but also to help put the information across that needs to go across, and how can we do it any better for you. So please, your feedback and voice is really important to us, and that's how we developed a group together from Manchester, Alderhay and Glasgow, and at Gosh as well. We do meet regularly to iron out all these kind of problems that we may have, but also how we can make our service better for the patient.